Yeah, good afternoon to all the third year pharmacy students. So this is Dr. Sunil Kumar. So I think last class we were discussing about thiazide diuretics. So let's continue our discussion. So let me share a screen. Yeah, I think the screen is quite visible to everyone. So in the last class, I was discussing about the paradoxical effect that is seen with thiazide diuretics, especially in diabetes insipidus. Okay, so thiazide diuretics are used to reduce urine volume in diabetes insipidus. So it is quite a paradoxical effect. Generally, diuretics will enhance urine volume, but here what we are saying, thiazide diuretics, especially, they are going to reduce urine volume. Okay, and this is quite opposite to the reaction, and I have explained this clearly in the last video. Here in diabetes insipidus, the major problem is there is a deficiency of antidiuretic hormone. Okay, and this antidiuretic hormone ADH, or which we call it as vasopressin, it fails to, or due to deficiency of this hormone, there is an inability of the nephron to reabsorb salt and water. The salt and water is not reabsorbed properly, especially water is not reabsorbed properly. Okay, so reabsorption of water becomes very poor, and there is an increased elimination of water. Okay, a large amount of water comes through urine, and that's why the urine will be highly diluted. Okay, there is a diluted form of urine that we are going to find. Urine is largely diluted. Okay, so now, as I told you, why thiazides, what kind of role does thiazides will play. Either you can use a derivative of antidiuretic hormone to increase reabsorption of water. That can be done, or you can go for thiazide diuretics. What thiazide diuretics will do, thiazide diuretics will block sodium chloride co-transporter. That is well known, we discussed clearly. It is going to block sodium chloride co-transporter. Okay, and by blocking sodium chloride co-transporter, especially in a distal convoluted tubule, especially in distal convoluted tubule, they will block sodium chloride co-transporter, and by blocking sodium chloride co-transporter, they increase excretion of sodium. Okay, I would also like to say that they prevent reabsorption of sodium, whatever the 5 to 8% or 10% of sodium that is reabsorbed, that will be blocked, that will be prevented. So that sodium comes in urine. Okay, that sodium comes in urine, and whatever the urine that is diluted in diabetes insipidus, okay, due to the effect of thiazide diuretics, sodium will be added to the urine. Sodium will be added to the urine, and urine becomes concentrated. Urine becomes concentrated. Okay, that is one thing. And as a result of increased sodium loss with thiazide diuretics, in order to compensate that sodium loss, okay, this renin angiotensin aldosterone system, which we call it as ROS, it will get activated. Okay, so if you know that in, so if renin angiotensin aldosterone system will be activated whenever there is a sodium deficiency. Okay, with thiazide diuretics, what you are doing, you are increasing sodium excretion, and you are adding sodium to the diluted urine in diabetes insipidus, and that will cause sodium deficiency in the blood, and that will activate renin angiotensin aldosterone system, and that will uh, uh, stimulate angiotensinogen. Angiotensinogen will be converted into angiotensin 1 by renin. Angiotensin 1 will be converted into angiotensin 2 by ACE enzyme, that is angiotensin converting enzyme, that is secreted by our lungs. Okay, and that angiotensin 2 will stimulate aldosterone. That is what we want in diabetes insipidus. So when aldosterone is stimulated, so immediately there is an increased reabsorption of, water. There is an increased reabsorption of water and sodium. Okay, and that will reduce urine volume. That is why the urine volume will be reduced. So this is a paradoxical effect That is especially seen with thiazide diuretics. Okay, thiazide diuretics will be beneficial in diabetes insipidus where the volume is where the urine is very diluted due to the secretion of large amount of water. So thiazide diuretics, by blocking sodium chloride co-transporter, it will just add sodium to the urine. Okay, and it will cause sodium deficiency in the blood. Thereby renin angiotensin aldosterone system will be activated, and as a result angiotensin 2 will be formed, and that will stimulate adrenal cortex to secrete aldosterone, and aldosterone will start reabsorbing salt and water. That diluted urine will the volume of the urine will be reduced. Okay, that is why we are using thiazide diuretics in diabetes insipidus indirectly to increase sodium concentration in the urine, and indirectly to activate renin angiotensin aldosterone system, so that aldosterone will be stimulated from adrenal cortex, and reabsorption occur, which is very poor. Reabsorption of water is going to be stimulated by aldosterone, which is very poor in diabetes insipidus. That's it. So that is about the use of thiazide diuretics in diabetes insipidus. Now coming to another thing is hyperglycemia. Hyperglycemia may occur with thiazide diuretics. Okay, the reason here it is clearly mentioned why there is an elevated blood glucose level with insulin, sorry, with hyperglycemia, with thiazide diuretics. This is due to both impaired pancreatic release of insulin. Okay, so generally what happens, insulin will be converted from pro-insulin. Pro-insulin will leads to active insulin. Here, these thiazide diuretics, they will interfere with the formation of insulin. They will interfere with the conversion of pro-insulin to insulin. Okay, that is one problem. Okay, and another problem is thiazide diuretics will also interfere with the tissue utilization of glucose. Okay, you know that in presence of insulin, tissues will absorb glucose, but here they will prevent the formation of active insulin by preventing the conversion of preventing the conversion of pro-insulin to insulin, and simultaneously they will also decrease the tissue utilization of glucose. Glucose will not be utilized by the tissues. Glucose stay more in the systemic circulation, and as a result of that, we have hyperglycemia. There is an enhanced blood sugar level. Okay, so that is what we call it as diabetes. Okay, so one of the major side effect of thiazide diuretics is diabetes. Diabetes can occur with the excessive or prolonged use of thiazide diuretics because they interfere with the insulin formation, and they also interfere with the glucose utilization. Okay, so that's it. So that is about these two things. And kinetics. Coming to the kinetics, the thiazide and related drugs are all effective orally. They are very well effective orally, and they are well absorbed from the GIT. The action starts within 1 hour, but the duration varies from 8 to 48 hours. I think I mentioned chlorthalidone, indapamide, metolazone, they are long acting drugs. Okay, that's why the duration varies from 8 to 48 hours. Okay, and all are excreted in the urine mainly by tubular secretion. Tubular secretion is a process by which these drugs are eliminated from the urine. Okay, and the tendency to increase uric acid plasma levels, same as loop diuretics. They will also have a competition. They will also have a competition with organic acid transporter. They will also compete with organic acid transporter to get excreted from the kidney. Okay, and as a result of that, uric acid on one side will try to bind with the organic acid transporter, and here thiazides will also try to bind with organic acid transporter. Okay, for their excretion. But here uric acid will fail to bind with the transporter. Diuretics, thiazide diuretics will bind fast. They are quite faster. Okay, they will bind with the transporter, and they will prevent the binding of uric acid to the transport system. Okay, so this is what we call it as competitive inhibition. I use the word competitive inhibition. Both will bind, both will try to bind with the same site, but instead of uric acid, so thiazides will bind with OAT. Okay, and thereby uric acid has to stay in the nephron. It has to wait for the other organic acid transporter. Okay, so meantime, so uric acid will be reabsorbed in the blood, and as a result, the plasma uric acid level will increase, and that will result in gout. Okay, there will be a formation of uric acid crystals or deposition of uric acid crystals in the joints, especially in the joints and skin, and that will result in gout. Okay, so the same what we discussed in loop diuretics. There are two substances which want to go out of the kidney or which want to uh, 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 reach the site of action by utilizing the same transporter. One is uric acid and another one is thiazide diuretics. But thiazide diuretics will have high affinity for organic acid transporter. They will bind fast, and uric acid will not be allowed to bind. That's why uric acid, it will be reabsorbed back, and as a result, blood uric acid levels will increase, and that will result in the formation of gout. Okay. Yeah, that is one thing. And coming to adverse effects, let me quote here clearly. You can see potassium depletion, that is hypokalemia. As I told you, if you are going to block the sodium, please try to understand. I think I have already cleared this. If you are going to block sodium chloride co-transporter by using thiazide diuretics in distal convoluted tubule, that sodium which is not reabsorbed, that increased sodium load will reach the collecting duct. And in collecting duct, as a result of this increased sodium load, aldosterone will be activated, and this increased sodium, some part of this sodium will be reabsorbed with aldosterone, okay, and potassium will be secreted. Okay, and I told you, as you should check the balance. So whatever the sodium that is going out, it is more when compared to the sodium that is absorbed by aldosterone. That's why diuresis will not be disturbed. But potassium, which is normal in the blood, every time when increased load of sodium reaches the reaches the collecting duct from distal convoluted tubule, so there sodium will be reabsorbed and potassium will be thrown out. Okay, and as a result of continuous excretion of potassium, you will have potassium depletion or hypokalemia. And as we know that along with potassium and potassium, sodium will also increase the excretion of hydrogen ion. That's why there is metabolic alkalosis. Metabolic alkalosis will be there, which is characterized by muscle pain, respiratory breathlessness, vomiting, diarrhea, okay, muscular cramps, and finally severe dehydration. Okay, so that is what we call it as metabolic acidosis. And increased plasma uric acid because of competition of uric acid and thiazides to bind with the same organic acid transporter for its further excretion. Okay, and uric acid will fail to bind. Thiazides will have high affinity for the transporter. Thereby, uric acid will be reabsorbed, and that will result in increased plasma uric acid. And hypochloremia, decreased chloride levels, which is associated with cardiovascular problems, which is associated with gastrointestinal disturbances. Hypercalcemia, hypercalcemia, I think I mentioned, because of decreased availability of sodium. Okay, I think I have shown you this diagram, if you remember. Yeah, here I have shown you. Because thiazides will block this pump, okay, sodium chloride symporter, and they will decrease sodium entry into the distal tubule. So sodium concentration in the distal tubular cell will decrease. As a result of that, sodium calcium exchanger will be there here. Okay, here you have sodium calcium exchanger. Okay, so what this sodium calcium exchanger will do, it will pull sodium from the blood into the tubule. Okay, one sodium molecule will come from blood into the renal tubule, and in place of that, three calcium molecules, Ca plus 2, three calcium molecules will enter into the systemic circulation. Okay, this is called sodium calcium exchange, and this pump is called as sodium calcium exchanger. So why this pump is activated? This pump is activated when there is a very decreased amount of sodium inside the cell. Okay, when there is a reduced amount of sodium in the cell, so sodium calcium exchanger will be stimulated, and it will pump one molecule of sodium. Sodium will come out from blood into the distal tubular cell, but in place of sodium, calcium, which is already present in the cell, okay, it will be pumped into the blood. As a result of that, there is increased calcium levels in the blood, and that is the reason behind what I mentioned. You can see here even. Yes. Yeah, that is the reason behind hypercalcemia. Hypercalcemia and hypomagnesemia. Magnesium level will also be lost. Hyperglycemia, I have mentioned the reason. So interference with the conversion of proinsulin to insulin, and also interfering thiazides will interfere with the utilization of glucose by the tissues. Okay, one disturbance in the formation of insulin, and another one is a disturbance in the tissue utilization with glucose, and it also increases plasma cholesterol level, male impotence. So this, I can say that, see, the male sexual hormone, that is a testosterone. I think you know, testosterone is mainly responsible for potency. Okay, so testosterone will be responsible, is one of the major hormone that facilitates or that promotes the secretion of sperm in male. And here, let me tell you, testosterone release is associated with zinc. Okay, so zinc is required for the release of testosterone. Testosterone. Okay, so you should know certain aspects, because when you know it, when you know the logic behind the problem, definitely you can remember that for a long time. So testosterone, which I have mentioned here, sorry, testosterone, which is released in presence of zinc. Zinc is very, very essential for the release of testosterone. What thiazide diuretics will do, they will deplete the store of zinc. They will increase the excretion of zinc. They will reduce the plasma concentration of zinc, and zinc will also be excreted in large amount. Okay, and when enough zinc is not available in your systemic circulation or in your reproductive circulation, automatically testosterone release will be disturbed, or less amount of testosterone will be released in comparison to healthy individual. Okay, or in non-thiazide individual who is not taking thiazide, if you compare with that individual, so individuals who are not taking thiazide, they have enough zinc levels in their reproductive system or reproductive circulation. But in persons who are taking thiazide diuretics, after prolonged use, there may be a chance that thiazides will deplete the storage of drink, so storage of zinc. Okay, zinc levels will come down, and as a result of that, testosterone release will be inhibited, or to a certain extent less amount of testosterone will be released, and that will result in decreased fertility in male. Decreased fertility in male, that is impotence, unable to produce offspring. Okay, so hypersensitivity reactions, skin rashes, dermatitis, inflammation of your skin, hemolytic anemia, okay, that is breakdown of RBC, and decrease in platelet count, that is called thrombocytic anemia. This is due to the hypersensitivity. It will trigger the immune system, and it will cause all these hypersensitivity reactions. So allergic reactions caused by thiazide diuretics. Okay, so this is about adverse effects related to thiazides. Now, therapeutic uses, you can use in hypertension, mild to moderate hypertension. Thiazides are very beneficial, and you can use it in heart failure, mild heart failure. You can use it in edema. You can use to prevent recurrent stone formation in idiopathic hypercalciuria. Okay, so here what happens when the when calcium is excreted in the kidney, please try to understand, when calcium excretion is increased, sometimes calcium, when it enters into the kidney, there may be a chance that there is a formation of calcium stone in the kidney. Okay, there may be a chance of formation of calcium stone in the kidney when its excretion is increased. Okay, but here, as calcium is not allowed to excrete, as calcium is reabsorbed more with thiazide diuretics, so there may be a formation of calcium stone in the blood. Okay, in bile, in case of gallbladder, or in case of heart, there may be a formation of calcium stone. But as the calcium excretion is decreased with thiazide diuretics, you can find that the calcium is not excreted in much quantity from the urine. That's why if in any individual, if calcium is excreted more by the kidney, and there is recurrent formation, repeatedly calcium stones are formed in the kidney, so give thiazide diuretics. Thiazide diuretics will prevent calcium entry into the nephron. It will reabsorb calcium. Okay. Thereby, more calcium stays in the blood, less calcium goes to the kidney, less formation of the stone. That's it. So that is the mechanism of that is the reason behind its utilization in a recurrent stone formation. And diabetes insipidus, where the reduced urine volume. I think I have explained several times. Okay, so they will add sodium to the urine, they will decrease sodium concentration in the blood, RAS will be activated, aldosterone will be activated, and aldosterone start reabsorbing salt and water, thereby urine volume will be decreased. Okay, and coming to next category, so that is weak or adjunctive diuretics. Okay, so I will discuss that later. So let me stop here. So I will continue the video after clarifying your doubts. Okay, thank you.